All right, we're rolling.
All right, I think I'll get started then. So you can see the layout of today's slides. We're primarily focusing on cardiovascular related things. In saying that though, we're starting off with Cardiovascular Anatomy 1, and it's technically not cardiovascular at this stage. We're actually just gonna be talking about the thorax for now, which might give you some sort of indication of at least where, like the sort of the layout of the place where the heart is located. We're gonna be looking at some of the spaces. We'll start with the bones, the muscles, and I believe we covered a lot of this in week 9 with Kyle, but I'll be taking you through a bit more detail in terms of like taking that further. So past the muscles and looking at the spaces specifically. So yeah, it's not really cardiovascular, it's more thorax. But let's get started. So we'll start off with the bones. And in this case, we're looking first of all at the ribs. And again, Kyle has covered sort of the classifications of the ways that you can describe these ribs. But here's just a good summary in case you've forgotten. With the classification 1, we're technically just thinking about how the ribs will attach to the sternum in the midline at the front. So we're thinking about true ribs, and those are ribs 1 to 7 that attach to individual costal cartilages that then attach to the sternum. So they're quite straightforward. With the false ribs, they're only 3 ribs, 8 through to 10, and they will indirectly connect to the sternum via common costal cartilages. So you can see, I'm not sure if you guys can see my cursor. Actually, let me get a little laser pointer up so you guys can, there we go. Hopefully it's not lagging too much, but you can see sort of these first couple of ribs there, they have individual cartilages in the blue. Whereas if you go down here to like ribs 8 through to 10, you can see that they have common cartilages. So they all sort of combine together and then they attach to the inferior part of the sternum. So those are your false ribs. And then floating ribs, they're kind of tucked away near the back. So those are ribs 11 and 12, and those don't attach to the sternum at all. So you can see they kind of fall short of even coming around to the front. So they're only at the back. So that's probably the easier one to understand. With the classification 2, it's based on actually the features of, or the anatomical features of the ribs themselves. So I'm not going to go into all the details of what each of the ribs like features are, but if you were to group them, and this is pretty much all you need to know for this level, even for our level, we don't need to know too much detail. Typical ribs will be anything from 3 through to 9, and they have all common anatomical features. So they'll have a head at the front, then they'll have a neck, then they'll have a tubercle. The tubercle is where it articulates with the thoracic vertebrae, and then you've got the body. So that's just going to be, the body is probably the most important part. That's the part that's actually spanning from the front to the back. And the reason why I say the body is important too, apart from just the fact that it takes up the most features of the rib, is that underneath the body, you've got this space called the costal groove. And that groove contains the neurovascular bundle, which we're going to discuss in a couple of slides time. And that's important clinically, which we'll discuss a little bit later. So just keep that in mind in terms of the major feature that you need to know about. With the atypical ribs, it's all of the other ones. So 1, 2, 10 through to 12, and they have some unique features. So just again, really simplifying it for you guys, with ribs 1 and 2, they have a bunch of grooves and a bunch of tuberosities. So for example, with rib 1, you can imagine that because it's so high up near the neck, there's actually going to be a couple of attachments for some of the neck muscles, which is why I'm not going into it in too much detail, because that comes in year 2. And then you might have grooves for some of the arteries and things that are passing through, like the subclavian and things like that. And the second rib also has similar attachments. With ribs 10 through to 12, they're just missing a couple of things. So, I mean, you can kind of see that in our floating ribs, you can see that it's very, very short. So it's going to be missing a couple of things, but they're also missing like tuberosities here and there. They're missing like some might be missing the tubercles. And honestly, it doesn't really matter too much at this stage. So just keep in mind that 3 and 9 and everything in between are going to be the normal sort of typical ribs. Okay. Then we come to the sternum. And again, the sternum is actually probably the easiest bone to understand, because it's just like there's no, like you don't need to remember all of these features that I've shown in this diagram. You don't need to remember like transverse ridges. You don't need to remember all the demifacets and stuff. The major thing you want to remember is just the joints that separate each part of the sternum. So the sternum has 3 parts. We've got the manubrium, we've got the body, and then we've got the xiphoid process at the bottom. Between them, you've got joints. And the major reason why we consider these joints is because some of them are palpable and some of them can be really good landmarks. So with the manubriosternal joint, this is probably the most important. We also call it the sternal angle. If you like I'm not sure if you can see this, but if you put your hand around here and sort of feel there, you can feel really like an anteriorly projecting surface, or like a point. And that's the landmark that you can palpate on any patient to be able to figure out what the manubriosternal joint is. So this is a secondary cartilaginous joint. It's lined with hyaline. And as I said, you can palpate it on your patient. And another name for it is also the sternal angle of Louis, or the angle of Louis. It is also the location of the second costal cartilage. So right over here, where I said you don't really need to know too much about the articular surfaces, this is probably the more important one to know, is that the second rib, as well as the second rib's costal cartilages, will be right where the sternal angle is. And so say, for example, you are doing you're doing like auscultation of some of the heart valves, and you really want to figure out, where's that fifth intercostal space or something like that. You can start here, figure out where the second costal cartilage is, and then move your way down. So that makes it a little bit easier. The xiphisternal joint is less important. So it's the one all the way down here at the bottom between the body and the xiphoid process. It's basically where the thoracic cavity stops. And there's also a couple of other things at this level. So you've got the inferior border of the heart. And because the inferior border of the heart plus its pericardium kind of fuses with the diaphragm, you're also going to get the central bit of the diaphragm being at that level as well. And then finally, I'm not going to be covering too much about the thoracic vertebrae because we had a whole sort of session on that with the back. So if that's still a little bit confusing, go back to those slides and have a look at some of those features. But remember that the ribs are there to be able to connect the sternum at the front to the vertebrae at the back. Okay, so hopefully that makes sense. And that those bones all together will form the thoracic cage. Now we come to the muscles. And I'm not sure if we covered this in our last session, but just to, again, clarify, you've got three muscles. Or you've got more muscles, but the three muscles between the ribs are actually much more important and clinically relevant. I'll go into some of the other muscles a little bit later. So they're really nicely named, really nicely named, because they're just given in the order in which you find them if you were going superficial to deep. So once you hit some of the external layers, you've gone past the skin, you've gone past the subcutaneous fat, you've gone past some of the superficial fascia, then you get to these muscles. So you've got the external intercostals. And the way I like to remember these and the way that faculty shows you to remember them is by thinking about the orientation of your hands when you are having them in your pockets. So they're going to be going sort of like this downwards. So I think it's like inferomedially. So that's kind of the position or the orientation of those fibers as they go down. So if you think about, if I was to then like imagine me pulling those fibers up, that's going to pull those ribs upwards and increase the amount of volume that I have within my thoracic cavity, which allows me to breathe. Now, just a quick note, most of these muscles are actually they're muscles of respiration. And so we'll discuss them more when you get to next year and think about the lungs and some of the muscles that allow for that. But these are muscles of forced respiration. So normally your diaphragm is the one that's doing all the work, and that's going to be a muscle we discuss today. But these ones will come in handy when you really need to like force a lot of air to come in or force a lot of air to come out. And some clinical conditions where, for example, diaphragm is not working, or you have like COPD or something where you have very little amount of air coming in anyways, you need these muscles to be activated. On the other hand, you've got the internal intercostal. So that's a layer deep to the external. And this is going to be hands on shoulders. So they're going superomedially. So they're going up and then towards the center. And these ones, if you think about me again, pulling down on the ribs, that's going to depress the ribs, and that's going to reduce the amount of space that I have in my thoracic cavity, which is for forced expiration, to really push out the air. And then finally, innermost intercostals pretty much does the same thing as the internal. The only thing that's different about it is the anatomical direction of the fibers. They're more vertical. So not directly vertical, but they're a little bit more vertical. So you can see that here. External intercostals going down and towards the center of the body. The internal intercostals going down and towards the lateral aspects of the body. And then the innermost intercostals just going directly down almost. So they all do similar things. And then you've got, so as I said, the important thing is the costal groove that's underneath the body of most of these ribs. And also, if you want to kind of specify exactly where they are, they're between the internal and the innermost layers of the muscles. This is something you'll see again in abdomen, so keep this in mind. It's not just something you see here. In fact, I'm pretty sure it's present in most parts of your body. So it's a very common theme that usually these neurovascular bundles are between the second and the third layer deep within that structure. So you've got that there. And what this means is clinically, when you're inserting, for example, a needle between the ribs, you want to make sure that you are not inserting it too close up here, so directly underneath a specific rib, because while you've got the vein and the artery being sort of nicely protected, that nerve is just out enough for me to damage it in case of some sort of injury. So if I damage that, I might lose innervation to like sensory innervation in a specific area, like a dermatome, or I might also lose a little bit of innervation to some of the muscles in that region, which is not ideal. So you should aim for around the middle, right? So that's the ideal spot. You can also go just above a rib, so just above the rib below the one that you want to put the needle in. And while that is okay, the problem is that you could hit these collateral branches. And I've kind of said that the collateral branches are not that important, and it's kind of true, but you want to still try and avoid damaging anything. If it's not possible, though, it's okay if you damage the collateral nerve because it doesn't do much. Okay, and just as a bit of a mnemonic, if you want to go from superior to inferior, you've got VAN, so vein, artery, nerve, and the nerve is the most exposed. Okay, here's the other muscle. So the chad of the thorax is the diaphragm, and it's the biggest muscle that I know of, I think. Or maybe there's bigger muscles, but I think I'm making stuff up. But it's massive. It's the primary muscle of respiration. So again, we'll discuss it more when we get to next year, but it is very, very big. And what it does is if you contract it, it's going to flatten. If it flattens, the lungs have more space. And so they can take in more oxygen. So it's the one that is normally acting to allow you to breathe. The right hemidiaphragm is generally going to be a little bit higher than the left one, just because, again, abdomen. So this will come up next year. You've got the liver sort of sitting on this side. So that side is going to be pushed up a little bit more, whereas on the left side, you don't really have much. The liver is kind of the bully of the abdomen. It's massive. What is it innervated by? It's innervated specifically by this named nerve called the phrenic nerve, but that's a boring way to remember it. So the way that faculty says to remember it is C3, C4, C5 keeps the diaphragm alive. And this will come up when you also do head and neck, because a lot of these nerve roots originate from the neck. And I think James sort of mentioned this in embryology of the heart, is that a lot of these structures that are in the thorax, including the diaphragm, including the heart, actually start off in the neck. So they will carry some of their innervation from the neck region down to where they are, which is why oftentimes a lot of these nerves are quite long, going from the neck through to the thorax and even the abdomen. There are three main holes basically in the diaphragm that allow stuff to travel through. And here they are at the bottom. So you've got 1, 2, 3, and those are the aortic, esophageal, and the caval hiatus. So the aortic, and these are not sort of like as I said, the diaphragm is not a flat muscle, it's sort of domed, which means they all happen at different vertebral levels. So the aortic hiatus is the one that's the lowest down. It's at T12. And that contains, of course, the aorta, given the name. It also has the thoracic duct, and it has the azygous vein. So generally, it's going to contain a lot of these vascular structures most of the time. The esophageal hiatus is a little bit higher up, and it's at T10. It contains, of course, the esophagus, but also the vagus nerves. And the way you can remember that is because the vagus nerve, actually, this might be a little bit new given you haven't done abdomen, but just remember the vagus nerve provides some parasympathetic innervation to the esophagus. So if you know that, I guess it might help to just remember that they go together. And then the caval hiatus, it's named so because it contains the inferior vena cava. It's at T8, so it's the highest one. And it has branches of the right phrenic nerve. So I think probably the most important ones, I think it's actually fairly straightforward just when you understand that aortic, esophageal, caval, they all describe what's going through it: aorta, esophagus, IVC. And if you want to remember like one piece of information, just remember where the nerves are, because the vagus nerve goes through one hiatus, the phrenic nerve, specifically the right phrenic nerve, goes through another one. And we'll discuss why it's only the right and not the left later. The way I like to remember it as well is, and the way I highlighted this is AOC. So just in case you're given like specimens and you just really quickly want to figure out which hole is which and you can't really see stuff going through it, you can just remember that it's A from the back, O in the middle, and then C in the front or most anterior. So AOC from top to bottom, sorry, from bottom to top. And then the other way to remember just what's going through or what the names are is through the number of letters in specific words. So if you want to remember, for example, aortic hiatus has 12 letters in it, that means it's going to be at the T12 level. Esophagus has 10 letters in it, depending on how you spell it. Don't use the spelling with E. Always remember it's the spelling with the O, E. That's going to be 10 letters, and that's going to be at T10. And then vena cava is going to be 8, so that's going to be at the level of T8. And those are really nice mnemonics, just in case you forget which one is which. Okay. Now we've got the layers. So I think, again, this is one of your learning objectives for when you do specimens. They kind of just like to ask, if I was a surgeon and I was to start from the very outside and try and get deeper and deeper and deeper, what layers would I be hitting at each interval? And so the layers that you'd be starting off with in any part of the body would first be the skin and superficial fascia. So you've got here the skin at the start, you've got superficial fascia. It also has some of that superficial fat. Once you traverse that, then you get to the more specific stuff to the thorax. So you start off with the intercostal muscles. And as I said, they're named really nicely because you know it's going to be external, internal, then innermost, and then you're done with the muscles. Endothoracic fascia comes next. And again, this is going to be very, very common. So this is like the deep fascia of the thorax, and you'll find superficial fascia and deep fascia everywhere. In fact, I think you probably remember if you go back to sort of upper limb, lower limb, they also have superficial and deep fascia, although it's not as important there as it is here. So you've got the endothoracic fascia, which you can sort of see here, this yellow layer just underneath the innermost intercostal muscle. After that, it kind of depends on where you are, because remember that this thorax is like, it's a pretty large space. So if I was a little bit higher up, kind of in the like more superior regions, and maybe also near the middle, I would hit the pleural layers of the lungs, and then I would hit the lung proper. Hopefully you're not going down so far that you would puncture the lung. You'd probably stop here. Okay, so once you hit the lung. If you're a little bit lower down, you might also find that you are at the level of the diaphragm. So you might either hit the lung or you might hit the diaphragm. And then of course, under the diaphragm, you've got other organs of the abdomen, which you might be hitting. Now, there are other muscles in the thorax, which I haven't discussed just because they're not actually that important. They're of anatomical significance, not so much of clinical significance, although they may be activated again when you are sort of in respiratory distress, when you really, really need even more muscles to be recruited to help you to breathe. So you've got things like transversus thoracis, and then you've got the subcostal muscles, which are just underneath, I think, sort of the lower ribs. If you want to know what they look like, just have a quick Google search. They do look pretty cool, but you just have to know that they exist and nothing more than that. Okay, now we get to the vasculature. So I'm going to try and make this as simple as possible, and try not to tread on the toes of like heart anatomy, as well as abdominal anatomy, because the aorta also goes into the abdomen. But I'm going to just focus purely on what's happening in the thorax for now. So you start off with the aortic arch. And I believe we haven't really discussed the anatomy of the heart yet. That's going to be in the next week. But just remember that the aortic arch comes off of the ascending aorta, which comes off of the heart. So it's one of two major outflow trunks coming out of the heart. So you've got the ascending aorta, it loops around as the aortic arch, and then it continues down here as the descending aorta. And then as you continue on, you can call it the thoracic aorta if it's in the thorax, you can call it the abdominal aorta if it's in the abdomen, and so on. But we're going to focus on this region here. Now, just remember that and again, this is to do with embryology, so you can have a look at those slides. This ascending aorta and aortic arch, they have a very unique sort of, I guess, diving pattern. So the way it goes is first it goes up, so superior, and then it sort of goes a little bit back. So it goes in the posterior part of the thorax, and then it goes leftwards, and then it goes down. So it goes up, sort of back, left, and then it goes down. As it does this, it gives off 3 branches. And those 3 branches are very important. Technically, there's like, if you look more distally, there's 4 branches. So just to simplify it for you guys, you've got basically 4 branches, right? You've got subclavians and common carotids on both sides. Okay, you've got left ones, you've got right ones. The only difference is that on the left side, they come directly off the aortic arch. Whereas on the right-hand side, they combine together first at the beginning as one big brachiocephalic artery, and then they'll split. So in effect, they're doing the same thing. It's just that they have different origins. Now, the subclavian artery we've seen many times in the upper limb. That's going to continue on as the axillary artery. Then it's going to continue on to supply the upper limb, so the left and the right ones. The common carotids are things that we're only looking at now in head and neck, but they're going to be things that go up to the head and neck. So they're going to supply all those structures there. There are also other branches that come off each of these arteries, but we're not going to talk about them today. So that's the upper limb, head and neck done with all the branches of the aortic arch. You've also got the ligamentum arteriosum, and that's not part of the aortic arch like specifically. That's one thing that connects the aortic arch with the pulmonary trunk. And that was just a fetal remnant of one of the structures that we discussed in our last week. So that was what allowed shunting because we want to bypass the lung. So you'll see that as sort of like a fibrous sort of structure. It's not shown here, but you can have a look. There's in your dissections, you might be able to see it. And then, as I said, it continues on downwards. Finally, just take note of the fact that the ascending aorta gives off coronary arteries, and those coronary arteries are going to be what supplies the heart. There's also other minor arteries that come off, like the esophageal branches and things like that. But again, very, very low yield. The most important stuff is just how this branching at the top happens. Then as we continue down, and if we're focusing on the thorax, remember how I talked about the intercostal bundle? And we kind of talked about the nerve, and we talked about how we can damage it. But where do the arteries actually come from? And where do the veins come from, if anything? So the arteries, they're kind of dual. So they come from the front and the back. From the back, you've got it coming off the descending aorta. So the back is the one that comes off the bigger artery. And that kind of, again, goes through underneath the costal groove. It continues in that bundle, so right between the vein and the nerve, and it continues up to the front, where it eventually anastomoses with the anterior artery, which comes off the front, and that comes off the smaller artery, which is the internal thoracic artery. The internal thoracic artery, if I go back, this is what I meant by branches coming off each of these three branches up here. From the subclavians, as they continue on, before they get into the arm and form like the axillary artery and so on, they're going to give off one small branch that sort of goes down like this. And that goes up to the front of the thorax, and that's what's supplying the anterior chest wall. Whereas the descending aorta and the thoracic aorta, those give off the branches that supply the posterior intercostals and the back part of the chest wall. So hopefully that makes a little bit of sense. If not, let me know and I can describe that in a bit more detail. So those are the just to give you a bit of an idea what the internal thoracic arteries look like. Remember that this is only showing one side. You've actually got them happening on both sides. So obviously the descending aorta, there's only one of them. It only goes down in the middle, whereas the internal thoracic arteries, they go on either side of the sternum, or you can say parasternally. They will later terminate in the abdomen, and I'm not going to go into these branches because they happen later on, but superior epigastric, muscular phrenic. Interestingly, you can take these these arteries out and use them during coronary bypass, just because you've got this posterior intercostal acting as a little bit of a collateral. So you don't really need to have both sides of your internal thoracics there. You can take one and use it during your coronary bypass surgery. Obviously, there's going to be some implications in that sense. And posterior intercostals I talked about, they come directly off the aorta. There's also subcostals, which really they're nothing special. It's just that they're the last intercostal artery. So they're going to be at underneath the 12th rib. So these arteries generally are going to supply the skin overlying the artery or this patch. You've got the intercostal muscles within or between those ribs. And then you've got the parietal pleura of the lungs that is just underneath. So just the covering of the lungs also needs a little bit of blood supply to keep it healthy. So those are the functions of the arteries. Then you've got the veins, and you've got two systems that work here. The azygous vein system is probably the more high yield one, just because they can ask you a lot more questions about it. And it's also quite unique because it's one-sided. So if you think back to everything we've discussed so far, everything has two sides, right? They come off on the left, they come off on the right. Internal thoracic also has two specific internal thoracics on either side of the sternum. This azygous system, though, is unilateral. And I think that's what azygous actually means. So azygous, not two-sided or something like that. And so it's not present on both sides. If you have a look at this diagram here, we're looking at an anterior view. Like, so if I'm sitting here and I'm looking at someone's chest wall from the inside, looking at the front, then I can see the azygous vein that's only on the, I think it's the right-hand side. Correct me if I'm wrong. I think it's on the right-hand side. And you've got two tributaries coming to it, which are the accessory hemiazygous vein and the hemiazygous vein. So the accessory hemiazygous is at the top, the hemiazygous is near the bottom, and they drain basically all of the, mainly the anterior intercostals. So you can see sort of at the front that they're draining all of those, the posterior intercostals, they're draining most of the stuff from the back. There are specific numbers, I think you can remember. So you might be, I don't think you'll be asked this in an exam, but just remember that accessory hemiazygous will drain most of the superior ones, hemiazygous will drain most of the inferior ones and only on a specific side, whereas azygous drains all of the posterior intercostals on one side, plus it receives all the venous drainage from these hemiazygous veins. So it's a bit confusing, but just remember that azygous vein is that really big vein that's going to be traveling up and then draining back into the SVC, takes all of those posterior intercostal drainages. It also is useful just in case you have an occlusion of the IVC, because usually the IVC will just go up and then it's going to be able to drain into the right atrium. But if in case it is occluded, you have this azygous vein actually acting as a bit of a transport mechanism or a bit of a collateral, just in case it gets occluded. So it goes all the way up to the SVC, and then the SVC can drain into the right atrium. So that's important. The internal thoracics are kind of the same as the arteries. So they will drain most of the stuff on the front, as the internal thoracic arteries supplied most of the stuff on the front, and it drains back into the brachiocephalic veins. So these veins up here drains into those two. And the brachiocephalic veins are kind of combined versions of both the jugular veins at the top that come from the head and neck, as well as the subclavian veins that are draining from the upper limbs. So again, you will discuss brachiocephalic veins later on, but for now, just remember internal thoracic is important. Now, interestingly, the internal thoracic vein, and I think I've written this in the comments just in case you want to have a look. If I have some sort of damage to the azygous system, then the internal thoracic may be able to take on some of that load of all the venous drainage. The only thing is that because the internal thoracic is so small and it's such a thin vein, it risks obviously a lot of dilation of that, which means you might be able to visualize it on imaging, or you might be even be able to see it if it's really that big on a patient, as well as risking it rupturing. So I think that was like one of the quiz questions that could come up on an exam, just to make sure that you know that the internal thoracic is one of those veins which is more likely to dilate because of how small it is, versus, for example, the inferior vena cava, which is so massive. If it gets more venous drainage, it's not going to dilate that much. Okay, that's internal thoracic. Now we come to the nerves. So there are a couple of nerves that are happening in the thorax, and some of them don't just stay in the thorax. They also do a couple of other things. But we'll start off with the phrenic nerve, which is more specific to the region that we're looking at. The roots, as I said, are C3, C4, C5. I'm going to keep saying this, and you're going to keep hearing this from faculty and from us in future years. So you should be saying this in your sleep. And the reason why it happens is because, as I said, embryology matters. So you've got it starting up in the neck, and you can sort of visualize the fact that it's kind of gone down, right? It's kind of moved downwards with the diaphragm, which also traveled inferiorly and carried its innervation. So from the cranial region, sorry, the cervical region. So the motor component is just going to be the muscles of the diaphragm. So that's the primary nerve that allows you to do your sort of normal breathing. So if there's damage to it, you might get to use some of those other muscles we were talking about for breathing. On the right-hand side, I think I mentioned this previously, it goes through the caval hiatus. So it's not shown here, but it'll travel through that specific hole in the diaphragm. Whereas on the left-hand side, it doesn't require any hiatus at all. It just pierces the diaphragm directly. So that's one major difference. In terms of sensory, and this is more like sort of visceral sensory, so it's not something that you can really well localize. It's more of like a dull pain. So if you were to have damage to the central part of the diaphragm, or you were to have damage to the part of the pericardium, which you can actually see nicely here. So on the heart, you've got the diaphragm, and that bottom part fuses with part of the diaphragm. If you've got damage to any of this section, you might feel a sort of dull pain that goes up through the distribution of the phrenic nerve. And because the phrenic nerve is C3, C4, C5 up here, that means you might actually feel pain near your neck or near your shoulders. Another way to think about it, if you don't want to think too much in terms of embryology, which I'd still encourage you do, is that C3, C4, C5 are also the nerve roots shared by another nerve called the supraclavicular nerve. And that arises from the neck region as well. That nerve supplies sensory innervation to the shoulder region and the neck. So that also explains why your body confuses which one is which. In terms of your dissections, this is something that confused me a little bit, just like differentiating between phrenic nerve and another nerve on the next slide, which is vagus nerve. Just remember that the phrenic nerve will travel anterior to the hilum of the lung. So again, the lungs, actually they're shown here. So you can see the hilum. The hilum is just like all the stuff going into the lung. And you can see that this nerve travels in front of that. You'll see why this is important for when we get to vagus nerve, which we'll go into now. So vagus nerve, and I'll just complete this for completion's sake with the dissections. If you're thinking about vagus nerve, remember that it'll travel posteriorly to the hilum of the lungs, as opposed to the previous one, which was anterior. Now, in terms of what vagus nerve is, it's actually a cranial nerve. So this is something you will look into in a lot more detail in terms of its other functions next year in head and neck. It's cranial nerve number 10. And its motor for the thorax is mainly going to be parasympathetic innervation for the heart. So it's going to slow down heart rate, it's going to reduce cardiac output, and it's going to be mainly innervating the SA node, AV node, etc. It contributes a little bit to the carotid bodies, and these are kind of like dilations on some of the, I think it's the internal carotid vessels, which will monitor your blood pressure. So those nerves are actually what allows you to monitor blood pressure and then make sure everything is fine. And both of the sides will pierce through the diaphragm through one hiatus called the esophageal hiatus. And so I said, remember, esophagus and vagus they go together. And sensory, there's none, at least in the thorax. So there's, as I kind of allude to here, the vagus nerve has many, many functions. It works in the head, the neck, the thorax, and it also goes down to the gut, which you will see in abdomen. So there are many functions, which is why I've only said in the thorax there's no sensory. The left vagus nerve, and both the left and right vagus nerve give off recurrent laryngeal nerves, but the left vagus nerve is clinically relevant because it gives off the left RLN, and that loops under the aortic arch. So if you can have a look here, left vagus nerve goes down. It then gives off the recurrent laryngeal nerve, this purple one, that then goes up to the larynx. And the larynx is sort of like your voice box. So it allows you to speak, allows you to breathe sometimes. So if you have someone who has damage to this nerve, it's going to mean that they may not be able to speak as well. So they're going to have hoarse voice. And the way that this can happen is if you have heart surgery and you've got, you're like working in this region around the aortic arch, or you've got an aneurysm of the arch itself for whatever reason, so it dilates too much and it compresses the nerve, then you'll have this sort of clinical presentation. So that's quite important. Whereas if you have a look at the right vagus nerve, while it can be damaged, it's less prone to because it doesn't really loop around anything. So it's not fixed to any regions that we might be surgically acting on. Okay, so that's the main difference. And it's called vagus because vagus means wanderer because it's really, really long and it does a lot of stuff. Okay, other nerves just to have a think about are going to be those intercostal nerves. And I've already talked about this a lot. But just remember that they are the roots, or the roots are coming from the anterior rami of the thoracic nerves. Then you've got the motor components. They're just going to be supplying the muscles that are between those ribs that they're acting on. And then the sensory function is going to be in the chest and sometimes in the upper abdomen, because they sort of, if you have a look at the dermatomal patterns, they kind of go downwards rather than just being straight patches. And the main important thing here is to remember that with intercostal nerves, they will form really unique and nice dermatomal strip patterns. And so this saves you a lot of time in terms of remembering dermatomes. Like if you think back to the upper limb, it was a lot more complex. Here it's actually really simple. And two main ones you want to remember, just in case you get asked it, or just for like your clinical skills as landmarks. T4 is going to generally be at the level of the nipple. And again, this depends on anatomical variation between people, but it's generally going to be around that region. And then T10 is going to be around the umbilicus, so your belly button. So T4 and T10, everything else happens in between. Sympathetic trunks, and these again become more clinically relevant when you get to head and neck. But for the thorax, they will be in the thorax, and they kind of act as paravertebral chains. So they're on either side of the vertebral column. So here's one, and then here's another. And they kind of look like, yes, they're chains, but they also have like these little ganglia, or you kind of think of them like beads on a thread on either side of the spine. And they will carry roots from T1 all the way through to T6. And they're going to supply sympathetics to the heart, which we'll discuss next week, the lungs, the trachea, and the esophagus. So a lot of different organs supplied. Splanchnic nerves, they're not as important with thorax, they're more important with abdomen. But just to give you some indication that if you think back to physiology and you remember sympathetic nerves, they only happen in sort of the middle section of your spinal cord. So you've got your like thoracolumbar region, right? That's going to be mainly like sympathetic nerves. Now, in order to get that sympathetic information down to structures below the diaphragm, to the abdomen, splanchnic nerves act as sort of a communicating route, whereby you take the information from the spine and are able to directly deliver it down below the abdomen. So again, not important for here, but just to give an idea that splanchnic nerves do exist. And then finally, a very, very, very short word on lymphatic drainage. Again, it wasn't so relevant for upper limb and lower limb, but for the thorax and for the abdomen, it's very important, just because there are some clinical pathologies related to these. So the thoracic duct is going to be what drains every part of your body except for the upper right quadrant. So if you have a look at the coloring here, you've got this blue coloring that's not going to be drained by the thoracic duct. Everything else here, the remaining 3/4 are going to be drained. And so here it is. If you have a look, this is the thoracic duct. And what you'll notice is if you think back to sort of your earlier studies of lymphatic drainage, the lymphatic system is going to be taking all the fluid from the body, returning it back into the venous circulation to allow it to then go through as systemic venous drainage, goes to the heart, and then it goes and supplies all the arteries and things like that. So it re-enters your systemic venous circulation through the left venous angle. So you can see that angle between these two veins is called the left venous angle. And that happens between the left jugular going up here and the left subclavian going down to the arm. And then by contrast, as I said, the upper right quadrant is going to be the right venous angle. And it's just called the right lymphatic duct. It's not got a special name like the left side. And then cisterna chyli, all the way down here. So you can see this really dilated portion. That's going to be what drains the lower half of the body mainly. So it's going to be the abdomen and then the pelvis. And again, that becomes more relevant for abdomen, but that will basically drain up into the thoracic duct and then drain back into the left venous angle. Now onto the spaces. So the mediastinum is the most important one to understand, especially for heart anatomy, because the heart is located in a specific region. And if you can specify it, rather than just saying it's in the thorax, that makes it more useful clinically as well as for your exams. So the mediastinum is just a space between both of the lungs. So your lungs are on either side of the body laterally. Between them is going to be the mediastinum, but that's not very specific. So I can divide it up into more specific regions. So I can divide it up into superior in the green, anterior, which is a really small region, middle, and then posterior. And the way I can do that is with a couple of cuts. So I've got one line going through here. And I did mention the sternal angle is super important, not only because it indicates the level of the second costal cartilage, but also because if I was to draw a line from the second rib all the way back to around the T4, T5 interval of the vertebrae at the back, then I would be drawing a line, and that line would allow us to separate superior from all the inferior mediastinums. So that is one division. And then the rest of the divisions kind of happen with the heart. So if you think about the pericardial sac around the heart, everything in front of it is going to be the anterior. Everything inside it, which is basically just the heart and some of the other vessels, is going to be middle, and then everything behind it is going to be posterior. So pretty intuitive. And for the purposes of our system that we're discussing, remember that the heart is in the middle mediastinum, but because the pericardial layers also go around some of the vessels that come out of the heart, it's not just the heart, it's also the aortic arch that will start in the middle mediastinum. It'll then loop upwards. So I said it goes up, left, up, posterior, then left. So it goes up into the superior mediastinum and then dives downwards into the posterior mediastinum. So just remember that for this section. But if you want a bit more detail, here it is. And this diagram, I think, is hands down probably the easiest one just to remember, rather than remembering a whole list of things. Just visualize this in your mind, and that'll tell you exactly where things are located. And obviously, things are not going to be just located in one mediastinum. So for example, the nerves, they will go all the way from the neck down to the thorax. So they're going to travel through many regions, whereas maybe something like the heart is going to stay relatively composed within the middle mediastinum. So I've highlighted some of the major ones here. You got the thymus, superior and anterior. You've got heart, aortic arch, ascending aorta would be here as well. Descending aorta, recurrent laryngeal nerve coming off the vagus nerve here, going back up to the larynx through the like on either side of the trachea and the esophagus. And I said the heart with the pericardial sac is there. Okay, and then the transthoracic plane. This is very, very important for your imaging because if you're given cross sections and even specimens, as you can see here, if you're given cross sections like a CT scan, an MRI, or you're just even given an X-ray or something, and you want to think about, okay, at this level, what would I expect to find? Then these are some of the major features you would see. And so this plane is, again, exactly at the division between the superior and inferior mediastinum borders. So we call it the sternal plane, goes from second costal cartilage to T4, T5. And a useful mnemonic to remember these is rat plant. So rat is rib 2, so that's what it's defined by, the aortic arch, and then you've got the tracheal bifurcation. So you can see the aortic arch right here in red. With plant, you think about pulmonary trunk, you think about ligamentum arteriosum, that fetal remnant, which is right here. And then you think about the azygous vein. So azygous vein, I don't think it's shown here. Maybe it is, and I've just forgotten, but it's not shown here. So the azygous vein will again drain into the SVC. And then the NT stands for just nerves in general. So you can see in yellow, you can see a couple of nerves being highlighted. Thoracic duct is going to be just behind the esophagus right here, and that's going to drain into the left venous angle. And then you've got parts of the thymus. So this thymus right here at the front, you've got superior lobes, inferior lobes being divided up by the transthoracic plane. And the reason why this is useful clinically is because you can actually palpate that level. So you know that little anterior prominence is the angle of Louis, and you can just imagine in your mind, if you were to open up this person, you would see something like this, where the line is there, and you've got a bunch of the structures behind it. And then finally, just to end off on the apertures, you've got the superior aperture and you've got the inferior aperture, just the top and the bottom of the rib cage. Superior aperture is at the top here. You've got boundaries, anterior, lateral, posterior. I won't spend too much time on this. It is quite boring, but if you want to have a read and just visualize this in your mind, go ahead. And this diagram really helps. But the main thing is that it has a tilt going sort of front and down. So I think just clinically speaking, or just anatomically speaking, that's useful to remember. It's not just flat. And basically it'll convey things that are going between the thorax and the head and the neck. So you got vessels, all these branches coming off the aortic arch, some of the things draining into the brachiocephalic trunks, lymphatics, such as the thoracic duct, not visualized here, and nerves mainly being the spinal cord, again, not really shown here, but of course the spinal cord goes through the entire body in the midline. Thoracic outlet syndrome is something we discussed in upper limb, but just to remind you that it is also relevant to the thorax. It can compress. So for example, if you have an extra cervical rib, then you will have compression of some of these contents that are going through the superior aperture and even going into the upper limb. And then the inferior aperture is not really that clinically significant. The only thing to remember is that the inferior aperture is going to be bounded by the diaphragm. So that's forming that boundary at the bottom. And so it kind of separates, it acts as sort of a physical barrier between the thorax up here and the abdomen down here. And then you've got all sorts of different boundaries that you can remember. Okay, and so that's it for anatomy of the thorax. I have purposely not gone too much into detail on the heart. I did briefly mention stuff about the pericardium, but that'll be more when we discuss heart, because you look deeper into the layers and it'll make more sense when we discuss the muscles and things of the heart itself. Now, before I go on, I just want to quickly make sure I haven't missed any questions. Okay, I think they've been answered pretty well, so I won't, if it hasn't, then send me a message, I don't mind, and I can answer them afterwards, but I think they've been answered pretty well, so I won't continue on with those. I think I'll just go into the cardiac cycle, so a topic in physiology. It's actually really short, and you might have noticed that the lecture, if you've done it already, is a very, very short lecture, but it's probably the most important lecture, if I might say so myself, for heart, and also just for like your future understanding, for example, of like ECGs and things like that, because it's basically how the heart pumps and what the phases of that pumping are. So what is the cardiac cycle as a bit of an overview? It's every cycle we define as going from one heartbeat to the next. So as a time frame, that's what it is. And it's composed of 4 main phases. And so these are the phases. You've got the filling phase, and all of these are named in relation to what's happening in the ventricles. So the ventricles fill, then the ventricles contract, then the ventricles eject all their blood, and then the ventricles relax. Okay, so it's relatively straightforward and logical in that sense. Some of the things that help with this are going to be the valves. So the semilunar valves, atrioventricular valves. We briefly touched on what these terms mean in physiology, I think last time, but you'll go into this in a bit more detail when we discuss anatomy. Plus the conduction system, which I think we really went into a lot of detail with that. That also has a role in this system. In general, just as a summary before we go into the next couple of slides, remember that the P wave of an ECG is going to, maybe I'll show you over here. So this is what a typical ECG waveform looks like. This little bump at the beginning is called the P wave, and that's going to be mostly to do with the atrium. That's when the atria contracts, and then it kind of goes back down because it's stopped contracting. And then when you get to this spike here is called the QRS complex. Plus you've got this little ending bit called the T wave. Those will be mainly to do with the ventricles. So the atria only has a little bit, ventricles does the rest. That's going to be the ventricular contraction, and then relaxation is just the T wave at the end, which we'll discuss later. But don't get too scared by this diagram here. Hopefully in the next couple of slides, we'll break it down and figure out what's exactly happening. Okay, let's start with the phases. So phase 1, as I said, filling phase, so the ventricles are filling. I think in the lecture, they break it up into phase A1, 1A and 1B. So 1A meaning the passive movement of blood into the ventricles, and then 1B being the active movement of blood into the ventricles. And it's kind of makes sense why it's divided like that, because what happens is when the atria are sort of relaxed at the starting, all of the blood, or at least a majority, 80% of the blood will move just by itself because the valves are open from the atria into the ventricles. But just to squeeze out that remaining 20%, the atria will contract. That pushes the remaining blood into the ventricles. So now almost 100% of the blood is in the ventricles. And that is when you see the P wave. Anytime you see something on an ECG, remember it's electrical. So anytime you've got a contraction happening mostly, you will see a wave. So that first wave, P wave, is just the atria contracting. And that's sort of shown here. Atria contracts, pushes it down there. Then you've got isovolumetric contraction. So let's just think about the contraction first. What happens is you've got obviously the atria pushing stuff into the ventricles. When the ventricle pressure is high enough and it's higher than what's in the atrium, what will happen is those valves between them will close. Because what the valves do is they allow stuff to move forward, but as soon as the pressure afterwards becomes higher, it'll push back on the valves and close them. So that's the second theme. Whenever you've got valves closing, you will hear sounds. And I think I discussed this in physiology in week 9. So the AV valves between the atrium and the ventricle close, and you hear the first sound, which is the lub sound. There's two sounds, lub, dub. The first one happens here. And the reason why it's called isovolumetric is because the volume, and because this is closed, this valve, and this valve is not yet open. So both valves are closed that go into and come out of the ventricle. The volume is fixed, which means the pressure inside is going to increase dramatically. And the ventricle is just going to keep contracting. So it's going to try and build potential energy before the next phase where we can actually push it out. And because the ventricles are contracting so hard, it forms this really complicated QRS complex. So that spiky, like that massive spiky bit in the middle, that's what this forms. Okay, so that's P-wave QRS complex done. And we've also heard the first sound. What about the other stuff? So with phase 3, all that pressure is built up. Eventually, when the pressure in those ventricles become high enough and they become more than the pressure that's in the outflow trunks, for example, the aorta in this case, the semilunar valves that separate those two are going to open. And that'll allow for all that blood to get removed out and ejected. And what you'll notice is that eventually the ventricles will contract, the ventricles will relax, the pressure will go down again because all the blood is gone, the valves will then close, and you finally hear that second sound, which is the dub sound. So that's all two sounds done. And the T wave is a bit weird. So it is relaxation. So you don't technically have like nerve impulses traveling through, but it's kind of like that last hurrah of the heart where it's like, oh, just going to squeeze a little bit of blood out. I think at least that's how I remember it. The T wave is just that little bit of extra contraction before it then finally just completely relaxes. So then you get the T wave, which was this little final bump at the end. Okay, and then finally phase 4 is just resetting for the next cycle. So this time, again, both the valves are completely closed. So it's going to be isovolumetric, fixed volume, and the ventricles have relaxed. So everything is closed, prevents backflow. And now eventually, as the ventricles start to fill again, the AV valves will reopen, filling starts, and then the cycle can recur again. Okay, now just to give you a little tip, if you're having trouble remembering this, and if you've just got a graph, what you'll notice is that whenever the ventricular, I'm not sure if it's shown here, I think it is. So the ventricular pressure, so this red line, whenever it intersects with the line that is responsible for the outflow trunks, which I think is the black one here, that's going to be when you hear sounds. So this intersection is going to be where that first heart sound is, and then this second intersection, actually, yeah, that makes sense. So you got S2 down here, and then you've got S1 down here at that intersection. And again, it's because one pressure exceeds the other, so the valves start to close. The other heart sounds are not that important for us at this stage. And that's it. So that's the cardiac cycle done. I will now pass it on to the next speaker. We'll talk about arteries, arterioles, distribution of blood flow, and I'll answer any questions you have in the meantime. Thank you.
Thanks, Jana. I will continue with arteries, arterioles, and distribution of blood flow. So this is really continuing on from what we've talked about in the cardiac cycle. So first, the ventricle contracts. So let's take the left ventricle, for example, which is going to pump blood to the rest of the body. But when the ventricle contracts, we want to think about the flow of blood out of the ventricles in kind of a different way. So when we think about the cardiac cycle, we realize that blood flows out of the heart in sort of like pumps, but that would result in blood flowing throughout the rest of our body in kind of like in a pumping manner. But we know that that's not 100% the case. Like blood still flows kind of continuously. And the reason for that is really the elastic expansion of arteries. So when the ventricle contracts, this causes essentially only 1/3 of the blood to flow directly through the like the arterioles or the arteries, and 2/3 of the blood flow actually contributes to creating sort of like pushing on the walls of the artery and expanding it. And once the ventricle stops contracting and once blood pressure sort of decreases, then the resultant elastic recoil of these arteries then causes the remainder 2/3 of the blood to then be pushed to continue flow. So this allows us to have relatively consistent blood flow, regardless of the pumping manner of the heart. So a couple of words, we just talked about systole and diastole. So systole is obviously when the ventricle contracts. Diastole refers to the period when the ventricle isn't contracting and blood is filling the ventricle. Yep, this is just a really quick slide. Something to note is that diastole and systole is not specific to the ventricles, so you can have atrial systole and atrial diastole as well. And in this diagram, it kind of shows that when the atria is in systole, the ventricles is in diastole, like how Janam talked about when blood is filling the ventricles. So this is the blood pressure of the aortic blood pressure graph. And on this graph, we can actually identify some key landmarks that we think about when we talk about blood pressure. So at the peak of every sort of cycle that the blood pressure goes through is going to be your systolic blood pressure. That kind of makes sense, right? So it's kind of like in this period in ventricular contraction. In systole, when it's contracting, you have the most amount of sort of force pushing the blood out. It makes sense for the systolic blood pressure to be the highest. Once systole ends, so let's take from this line onwards. So this is where systole starts. After it ends, there's a little notch called the dichrotic notch. There's more information in the comments of the slide if you're interested. To a deranged physiology website, but that's beyond the scope of what we need to know. But there's essentially a notch that indicates the end of systole and the start of diastole. And as diastole happens and there's less force pushing the blood out, slowly the pressure is going to drop until eventually systole starts again. And at the base, or like the lowest point, is what we call our diastolic blood pressure. So the peak is systolic and base is diastolic. You might remember, when you take blood pressure readings, we take two numbers. The top one is going to be systole, the bottom one or the second one is going to be diastole. Pulse pressure refers to the difference between systole and diastole, the blood pressures of them. And there's another idea called the mean arterial pressure, which is the diastolic blood pressure plus 1/3 of the pulse pressure. So we're going to talk about controlling blood flow through arterioles. Arterioles in particular are very important in the circulatory system for controlling blood flow. By changing the diameter, and by changing the diameter, we change the resistance to blood flow, and this changes the amount of blood flow to particular organs or muscles or places in the body. For example, we prioritize flow to muscles during exercise. And this is all done really through a couple of different mechanisms. So we've got sort of metabolic control, myogenic mechanism. So these are two local controls under local control. And then we have mechanisms under systemic control, which is like neuronal and hormonal. Everything at the end of the day is going to end up with smooth muscle contraction, and it's kind of organized in the way that you see on the diagram on the right, where you have smooth muscle kind of wrapping itself around the blood vessel, and it's going to contract. But starting us off with metabolic control under local control. Metabolic activity obviously will result in local chemical changes. So we're going to have increased, for example, CO2, decreased O2, all that good stuff. And these sort of changes in chemicals is the trigger for dilation of arterioles, which increases blood flow to that region. And this is especially important in skeletal and cardiac muscle. The myogenic mechanism. Myogenic refers to essentially the smooth muscle surrounding the blood vessels. basically, when blood pressure increases for whatever reason, the smooth muscle stretches. It kind of makes sense, right? You're going to push, there's more force pushing on the surface of the arteriole, so the smooth muscle also gets stretched. And as the blood pressure increases because of that, what actually happens is the smooth muscle has reflexive contraction. So when the blood vessel gets stretched, it reflexively contracts itself again in order to maintain constant blood flow. By contracting itself again, it actually results in a further increase in blood pressure. However, what is actually super important for us is to maintain constant blood flow. The blood pressure increase isn't super important, but what is super important is the constant blood flow that results, which is why the myogenic mechanism is important, especially in areas like the brain and other organs in the body. So under systemic control, we've got neuronal, which is the sympathetic nervous system, and hormonal, which is a bunch of hormones traveling through our body. As for neuronal, the reason I say it's sympathetic is because there's not really any significant parasympathetic control of blood vessels except at the genitals. And we have sympathetic fibers that release noradrenaline, which is a neurotransmitter, which acts on adrenoceptors, leading to vasoconstriction. As for hormonal, we've got a bunch of different hormones. Adrenaline acts on alpha adrenoceptors for constriction, so that's alpha-1, I believe, and then acts on also on beta-2 adrenoceptors, but this time it causes dilation. So you're going to have dilation of one and constriction of the other in order to redistribute blood flow that is conducive to sympathetic activity. So kind of like taking away from the gut and redistributing it to the blood. To the skeletal muscles. We have another hormone called angiotensin 2 and also ADH. Don't worry too much about them. Of these two, the main one of note is adrenaline, but these ones cause constriction. We have atrial natriuretic peptide, ANP, which causes dilation. And that's that from me for now. I'll answer questions in chat.
Yep, thanks, Deepak. I'll move on to my section now, which is all about microcirculation and lymphatics. So I'll just share my screen and we'll get started. Okay, so we're going to be talking now about microcirculation and lymphatics, and they're basically talking about the very end of everything covered by, I guess, Jainam and Deepak. So we've talked about the heart, talked about the arteries and the veins. Now we're going to talk about where those two meet at the very end and where they're going to actually perfuse and give nutrients and take away waste from the tissue itself. So we'll start off by having a general overview over here. So this is sort of the notes that I made last year for this topic. It's very, very small, so you don't have to actually know too much for this topic. There's a couple of key ideas here and there, but if you're just sort of wanting to look for an overview, here's a sort of small diagram that I've made that you can refer to. We'll start off with the key idea first, which is sort of the whole pathway of blood flow. So we already learned about from the previous sections about how blood is coming out of the heart via the ventricles, and then how it's being spread throughout the body through vessels, right? So the important thing to understand first is that your blood, at least for systemic circulation, is going to start in the left ventricle. Then it's going to go through the aorta to end up in arteries, right? Or branches of the aorta. Then from the artery, it's going to reach the smallest branch, which is called the arteriole. And that's when it's getting ready to actually perfuse or essentially give nutrients to certain tissue types, right? So the arterioles or terminal arteriole, they're going to then pass through what's called a metarteriole, which is sort of the transition between an artery and a vein. So it's between an artery and a vein, and that's called a metarteriole, also known as, and also a thing called thoroughfare channel, which we'll show in a bit in a diagram as well. And then from here, it's actually going to enter capillaries and then give nutrients to cells. And that'll be shown more clearly in a diagram in a second, but just keep that in mind in terms of how this whole branching occurs. You start off with a very big idea from the left ventricle, then the big branch, which is the aorta. You build your way down, branching further and further until you reach that smaller arteriole. Then you get that metarteriole, thoroughfare channel, and then capillaries. And then from there, you can finally have exchange of gases, for example, like oxygen. And then from here, you also have the exchange of things like carbon dioxide to get rid of from the cells. and then back up through the capillaries into the arterial thoroughfare channel system, out through the venule. And yeah, that's sort of how you have this blood being moved around and perfusing tissue. And the diagram at the bottom here shows exactly that. And it shows how this, I think I'll get a pointer up so it's a bit clearer, but you can see over here that you have the arteriole. From there, you have this whole branching occurring. And this capillary system, or this capillary bed, from here, we're able to exchange all the nutrients. But also a very interesting feature of this is that you can actually turn this on and off depending on the demands of the tissue, which we'll see in a second. But once it reaches the venule, it then goes back into the venous system, so via the veins, the SVC, IVC, and then ends up back at the right atrium of the heart, where it'll go back into the lungs and get oxygenated again. But that's already something you've covered with the previous sections. The important part here, though, is that the reason we have this system set up where we are sort of, I guess, supplying oxygen to tissues through this very dense capillary network is that we can actually, I guess, control how much blood is reaching certain parts of the body by constricting or relaxing sphincters that are located in the capillaries, right? So these smooth muscle sphincters, called precapillary sphincters, can be constricted so that they can stop blood flow through the capillaries, or relaxed to allow blood flow through them. And therefore, it'll allow you to either have more blood in the capillaries and therefore more blood in the tissue, or less blood in the capillaries and most of it just going straight through the thoroughfare channel and then ending up in the venous system again. So not basically doing anything there. And that's sort of the main idea about why we have those sphincters there, because when they're open, they're useful for actually getting the tissues perfused. But when they're closed, then the tissue is not going to get perfused and it's just going to pass straight through. It's just sort of being efficient with the blood, the limited blood that you have, and ensuring that it's passing through quickly and only being used where it's needed. And I think in the notes there as well, I've put a little note about this whole process being called vasomotion. That's how it's referred to in your physiology textbook. And yeah, it's essentially to deal with the oxygen demand of certain tissues. So that, for example, skeletal muscle might be using this more actively, but things like adipocytes, which are not as metabolically active, they might not require as much blood, then they're not going to be using this as much as well. Okay, so that's the whole system there. And this whole process of, and I think the labels are gone, but the process where we had stuff coming out of the capillaries and to the cells is called filtration. And the process where cells are then depositing stuff into the capillaries is called absorption, because it's absorbing stuff into the capillaries, right? We're thinking about it from the perspective of the capillary itself, not from the cells. So things coming out of the capillaries, filtration, things going into the capillaries, absorption. All right, and then here's a little slide as well, showing probably some of the more important ideas for this topic, which is talking about the forces, which are called Stirling forces, that actually govern the movement of fluid in capillaries. There's two main forces to consider, which is the hydrostatic force, which is, I think, mentioned by Deepak before, which is the blood pressure, the actual force of the blood pushing on the vessel walls or the capillary walls. And there's also the oncotic pressure, which is sort of like an osmotic pressure where you have blood proteins pulling the fluid in, right? Because what's happening is that in the blood, you have I think there's like a bunch of proteins floating around in the blood, but as a result, what's going to happen is that you're going to have water or the blood contents wanting to move out of those capillaries into the tissue surrounding it. That's because there's higher amounts of protein in the surrounding tissue. So that's sort of the hydrostatic pressure and oncotic pressure, and they both act on the blood to either push it into the surrounding tissue or pull it back into the capillary. And with the blood pressure, because you're going further, because the capillaries are very far away from the heart and they're very, I guess, terminal branch of the arteries, they're going to have very low hydrostatic forces acting on there, or the blood pressure is going to be very low there because you've come very far from the heart. And so the forces will gradually subside over time, over that distance. Whereas the oncotic forces are constant across the capillary because that sort of ECF environment is pretty much constant across that area. The next problem that we come across, though, is that even if there is absorption, right, even if you're having net absorption, or I guess you're having fluid net result back into the capillary, there is still this problem where the movement of fluid is occurring primarily out of the capillary. So in other words, you're having filtration absorption occurring, but the net effect is that you're having more of the fluid actually coming out of the capillaries. And if that sort of just is left unresolved, it means that you're going to have fluid building up outside the capillaries, and then you're going to have edema, which is a thing you want to avoid. That's why we have this second thing in place called the lymphatic system, which is basically there to drain that excess ECF, but it also has that second immune function as well, right? So it's draining the ECF to prevent edema, but it's also passing it through some lymph nodes and checking it for any pathogens before returning it back into the venous system, which is shown on the right there. That's all you have to know about it at this stage. You're going to learn more about the anatomy of it later on as well. Probably in second year, where they talk about how the lymphatic trunk and the lymphatic ducts connect with the subclavian vessels, the veins. In terms of clinical correlation, probably the most important part is understanding why do we even care about filtration, absorption, and lymphatic drainage. It's because if we have either too much or too little of any of these occurring, we could end up with fluid buildup or not enough fluid reaching a particular area. So you can imagine that if you have hypertension or high hydrostatic forces or high blood pressure, it's going to push more of the fluid out. So that's why you have excess filtration occurring there. If you have inflammation as well, in inflammation, you have higher vascular permeability. And so that's going to also result in excess filtration, which is why you have edema when you have inflammation as well, because the contents of the blood sort of moving out to allow immune cells to go out. If you have malnutrition, you actually have reduced plasma proteins because you're having less intake of that in the first place. And therefore, you're going to have a lower oncotic pressure, less of an osmotic gradient pulling the blood out. And so that's why that's sort of what happens in liver disease and renal disease, where you have sort of that, I think, where is it? I think on the slide below, I also described in the notes that renal disease is because you're losing the proteins through the urine, which is why you're having this also occurring there. And you also have this third aspect as well, which is if you have reduced lymphatic drainage, then you're not removing all the excess ECF. And as a result, that's going to result in buildup of fluid. And that can be something like a lymph node tumor, which is impairing drainage of the lymphatic system. So that's sort of all you have to know. It's not that much for this section. And I'll pass you on to our next topic.
Thanks very much, Jono. So we're going to be looking at atherosclerosis. Give me 1 second to bring it up. Sorry. Okay, can everyone see that okay? Perfect. Okay, so atherosclerosis is kind of, I imagine most of you guys know that having high cholesterol is bad for your cardiovascular system. I can't speak today. My apologies. It's bad for your cardiovascular system. You might not know why though. This is sort of the link. So this is why having high cholesterol is bad for you. Which is basically that if you think back to lipid transport, so you go back to what we did in semester 1, biochemistry, we learned how cholesterol was transported around the body. And the major vessel for cholesterol transport, or at least the particle with the highest percentage of cholesterol, it can be up to about 60%, is low density lipoprotein, LDL. So if you have a lot of cholesterol in your body, there's going to be a lot of LDL in your circulation. Now, usually that's okay. It's just, providing energy to your cells. But under certain conditions, usually when the blood vessel lining is already damaged for whatever reason, that cholesterol can start getting into the actual lining. So it gets into the endothelium on the wall of the plasma membrane. And then it starts to create a lot of problems. And it slowly builds up over time. It sort of creates a big lesion in the side of the blood vessel. And that can over time both narrow the blood vessel, so it can sort of like make it a smaller and smaller space the blood has to squeeze through, which can be bad for you just getting blood to where it needs to be. And it can also rupture. And when it ruptures, there's a pretty big risk of things like clotting. So it is potentially quite dangerous. And this is a really insidious disease. So everyone's vasculature is constantly at risk of developing atherosclerosis, and it happens over, as the diagram shows, decades. So you don't know, it's very hard to tell how quickly this is happening. We sort of have to look at someone's veins or arteries at any point and say, okay, well, this is a snapshot in time. We sort of have to work off, oh, you're younger than we'd expect this to happen, because it will happen eventually. So I don't know if they've changed the lecture because they used a pretty old one for us, but the lecturer sort of had a really morbid little bit where it's like, we're all going to get atherosclerosis and die at some point. But yeah, so we do our best to try and stop it. Now, how does atherosclerosis actually happen? So I went over a sort of a overview of it. This is the details now. So that LDL, full of cholesterol there, it gets in after we have some sort of damage. So hypertension is a risk factor because high pressures can damage the lining. Lipids are a risk factor because you have more LDL, and they can also damage the lining. So that's a nice little double whammy. And also smoking byproducts. So smoking, you produce a bunch of toxins, and those can then go and damage your blood vessel lining. The LDL, once it gets into the actual endothelium, it starts to oxidize, which, among other things, causes the cells of the endothelium to express adhesion molecules. Now, if you remember immunology, you'll remember that the adhesion molecules are basically what makes macrophages migrate to that region. So macrophages are all going through the blood, and they're all sort of bouncing around the walls of the blood vessels. The adhesion molecules make them stick and stay in one place instead of just bouncing past. So that's what's happening here. We're sort of recruiting macrophages and monocytes, which are the precursors to macrophages, from the blood, and we're pulling them in as if there was an infection. There's not. So these macrophages, instead of eating a pathogen, they phagocytose that low-density lipoprotein, and they become foam cells, which is sort of big fat macrophages full of cholesterol. Among other things, they also release inflammatory markers. So a lot of things you'll notice here are sort of snowbally. So we get a little bit, and then that makes things worse, and that has more flow-on effects that make it worse again. There's not much down regulation. There's not much negative feedback. We also get activated T cells, which migrate to the area. So these are sort of regulatory T cells, and they release cytokines, immune mediators, which will make things worse again. So they increase adhesion molecules, so we have more macrophages. They make foam cells develop faster, and they help just overall develop the plaque, which is a sort of building little mass of cholesterol, well, LDL, foam cells, and just sort of general detritus there. Now, the endothelium also has smooth muscle. So over time, that's going to create a cap of smooth muscle cells over the plaque. And so that is sort of a double-edged sword because it protects the plaque from rupturing, which is kind of good because we don't want it to rupture and create a clot, but it also helps it grow more and more, basically. And so it becomes more and more of a problem when it does rupture. Because it usually does eventually. And there's little calcium crystals which help sort of stiffen the artery, which is not great because we want our arteries to have a little stretch to them. I don't know I can't remember if we've gone through stuff like elastic recoil, but you need to have a little pliancy to your arteries, basically. And then eventually, so if the plaque ruptures, that creates a lot of debris, it creates a lot of narrowing, which can create and potentially causes clotting, which results in thrombosis and potentially a huge block. And if that happens in the wrong place, especially you're talking about places like your coronary arteries, that is very bad. That's like STEMI territory. Okie dokie. So this is just a really quick aside. This is not super high yield. You can have two types of lesions. So like either you have stenotic, which means like it's on the inside of the artery, so the artery gets smaller, and you have non-stenotic, which is on the outside of the artery and makes it, which doesn't make it smaller. So the stenotic one is sort of a little bit more, how do you say, predictable. So because you can sort of see the progression as it goes. It's sort of more progressive thing, whereas the non-stenotic is more likely to result in sort of an unexpected event. So like out of nowhere, it sort of ruptures and creates a clot. So that's not great. Okay, so in terms of treatment, this is sort of the main thing. So atherosclerosis, you need to understand the drug. So we're going to take this a bit slower, and I'll just walk through it at a time. So here, in like options 1 and to a degree 2 and kind of 3 of the pharmacological treatment here are about prevention, especially the first one. So it's basically, how do we stop a clot from forming in the first place? Because this is our big risk factor. Atherosclerosis is risky, not necessarily because of its immediate effects, although those are bad, The real catastrophic risk is if there is a rupture and a clot. So we want to minimize the risk of that of atherosclerosis developing in the first place, and also of the clot happening. So lipid-lowering drugs, we're going to talk about these more later, so I'm not going to spend too much time on them now. You can have statins and fibrates, which target different types of receptors, and so they and also just cellular processes which produce lipids. So they try and lower the amount of LDL, which is kicking around in your body at any particular time. Cholesterol absorption inhibitors to reduce the amount of cholesterol, again, same sort of idea. These are all similar things, which sort of just lower the amount of cholesterol and LDL in your body. And by doing that, they can then reduce your risk. So we can't really prevent this from happening over, like, the fullness of time, but we can slow it down, definitely. We also have antiplatelet drugs. So you probably have heard of aspirin. The reason that one would take aspirin is because it stops platelets from sticking together. You'll remember platelets are a major factor of how we create a clot. If you stop them from sticking together and coagulating, then you can stop clots from forming. So that's a preventative medicine. Now, anticoagulants are a little bit interesting because they're primarily a preventative thing. So like aspirin, instead of targeting platelets directly, they target clotting factors, which are what platelets use to help. Which are associated with platelets in a clot. So they have a slightly different mechanism to do a similar thing. And so they stop the clot from forming, ideally, especially stopping bigger clots from forming. There's also, if you look at, when we get to the next slide, is sort of a summary thing. Faculty says they reduce the size of clots. As far as I can tell, they don't directly reduce the size of clots. It's more that the body has ways to get rid of clots naturally, and this sort of stalls out the clots so that the body can do so. Yeah. So broadly speaking, the first three are more about stopping clots from forming or slowing the formation of clots. So trying to, hold back the tide. Now, the fourth one here, fibrinolytics, that is actually breaking down clots. And it's using the same sort of natural pathways that anticoagulants are, letting work. Fibrinolytics are actually kicking them up to a higher notch. So two important ones I called streptokinase and tissue plasminogen activator. Both of them sort of enhance the conversion of plasminogen to plasmin. So plasminogen is a substance you find in clots. When it gets converted to plasmin, it then breaks down the clot. So that's the body's natural pathway for actually breaking down a clot. What we do here is we just kick it up. So we make it easier to convert plasminogen to plasmin, which means that the body will naturally break down that clot faster. Okay. The difference between them, so TPA is newer, and it's what we call a fibrin-specific fibrinolytic. And that's slightly better, it has a better side effect profile, basically, because there's less risk of overall bleeding. Which is the overall thing, by the way. Pretty much all of these drugs, the major side effect is just a big neon sign saying bleeding. Because, surprise, surprise, clotting does have a function in your body, which is to stop you losing blood, among other things. And if you take that away, you take away the body's ability to clot, to stop you losing blood, and then you get a nick, like internal bleeding after a surgery, external bleeding, whatever, you can start losing blood very quickly. And that can be a big problem. So that is the major side effect to be worried about for these guys, that they do increase the risk of bleeding because we're breaking down the body's natural mechanisms of preventing it. We can also have non-pharmacological, so lifestyle changes, as with almost any condition. In terms of surgical intervention, so we can do things to try and repair or replace the part of the artery that's affected, and we could also potentially use a stent. So a stent, I don't know if you guys have talked about this too much. A stent is like a little hollow tube, and so it folds up into a really small diameter. You put it into the artery and then you inflate it, and it becomes a bigger diameter. So it pushes out the artery and makes it sort of bigger and keeps it open. It's really cool. Look it up. But yeah, so this is sort of the summary diagram from faculty about it. And it does a pretty good job of summing up everything. So you'll see again, antiplatelet and anticoagulant drugs, they both target the formation of the clot itself. So they are sort of inhibiting that pathway, whereas fibrinolytics are sort of boosting or overclocking the body's natural breakdown pathway. So again, we're all in the first two. We're trying to stop a natural process, and in fibrinolytics we're trying to accelerate the other natural process. So we're in all of these things. We're sort of there's a little seesaw of clot formation and clot breakdown, and we're trying to push it more towards breakdown and less towards formation, basically. Yeah, so that's pretty short and sweet. Feel free to ask me any questions in chat if you are not sure about that, or if I didn't say anything clearly. But yeah. That's pretty much it. And I'll hand you guys over to Deepak, I believe, for cardiac biomarkers.
Yep. So let me screen share. So back to me for cardiac biomarkers. So when we think about cardiac biomarkers, we're thinking about sort of stuff that's specifically inside cardiac cells that enter the blood, that in the presence, like once we realize that it's in the blood, we can realize that there's some pathology going on in the cardiac system, or specifically with the heart. So let's talk about the pathologies first. Coronary heart disease. So we just talked about atherosclerosis and all that good stuff. When it happens to coronary artery, so that's arteries supplying the heart itself, this causes obviously damage. Like when the heart is not getting blood supply, then obviously the heart cells eventually die, right? And that is the gist of acute coronary syndrome. Essentially, it's any condition causing reduced blood flow to the heart by these coronary arteries, the leading symptom being chest pain. And when we have such little blood flow, that the cells can't function properly, it can lead to a myocardial infarction. Myocardial refers to the myocardial cells. Infarction is basically death of these cardiomyocytes due to obstructed blood flow. Diagnosis of a myocardial infarction very specifically requires detection of cardiac biomarkers as one of the key things, because when these cardiac biomarkers are released, that is indicative of sort of death of these cells. So you kind of need this to diagnose an MI. And also, obviously, symptoms of ischemia, for example, chest pain, like we briefly mentioned. There's a lot of different names here that can get a bit confusing. Acute coronary syndrome is kind of like the continuum that has a lot of different severity of reduced blood flow. So for example, angina, which is just chest pain, is not as bad as STEMI, which is kind of which is a myocardial infarction. And this all falls under just coronary artery disease or coronary heart disease. At the ends of this spectrum or continuum is what the NSTEMI or STEMI is, and it stands for an ST elevated myocardial infarction or a non-ST elevated myocardial infarction. In an ECG, you'll have this pretty iconic waveform, which is a PQR, like the QRS complex with a P and a T at the end. And between the S and the T is what we call the ST segment. And in a STEMI, which is a ST elevated myocardial infarction, you can kind of see how the ST segment is raised up from the baseline. While in an NSTEMI, it can either be normal or it can actually be depressed, the ST. So it's a non-ST elevated myocardial infarction. The difference between these two lies with the actual pathophysiology of what happens. So in an NSTEMI, there's only partial vessel occlusion, so only partial infarct, while in a STEMI, there's full vessel occlusion, and the whole thickness of the myocardium gets infarcted, sort of, while in NSTEMI, only part of the myocardium is damaged. Now let's talk about the cardiac biomarkers necessary to diagnose either of these things. So infarction, again, super quickly, is just tissue death, so that will release enzymes and proteins. These can be specific or non-specific. Ideally, we want to find an enzyme or a protein that's released specifically from cardiomyocytes, because only then can we actually say it has to be cardiac in origin, like the pathology has to be cardiac in origin. For example, we can say myoglobin, which is just a heme-containing protein in heart and skeletal muscle. While, because it's non-specific, we don't actually know if it's specific to the heart, right? But it's still also pretty important to look at other biomarkers. So myoglobin has early release 1 to 2 hours after an AMI, an acute myocardial infarction. Creatine kinase, which is again present in heart and skeletal muscle as well. However, there's a specific isoform of creatine kinase, which is MB, which is actually heart specific. So this is pretty important for us. Cardiac troponin. So this is the gold standard that is very cardiac specific. It is detected 4 to 10 hours after an AMI, and it pretty prolonged. So it peaks 1 to 4 days after and is abnormal for up to 10 days. This is kind of like a graph showing us the time course of these cardiac biomarkers. But what I want you guys to take out of this is the fact that different myocardial infarctions can occur to different degrees. So really the degree to which the infarct happens means leads to the degree to which the cardiac biomarkers are released into the blood. So in a large MI, there's going to be a whole load of troponin, but in a small MI, it's also possible for there to be like pretty small amounts that doesn't really, isn't really like a super big red flag for us. But yeah, obviously, again, we have myoglobin and CK isomers versus creatine kinase MB, which is the one that's specific here. And that is that. Now, I talked about how cardiac troponin is specific to cardiac tissue. However, it's specific to cardiac tissue death, but that is not necessarily always going to be an acute myocardial infarction. Cardiac tissue death can occur for other reasons as well. So, for example, when there's demand stress, so when the demand of the myocardiocystes exceeds what it can do, then that leads to the death of those cells and release of cardiac troponin. Obviously, in myocardial ischemia or myocardial infarction is what we're looking about. And just direct damage due to myocarditis, which is a viral infection most of the time. And we have renal impairment as well. So it's important to think about a lot of other stuff when we see elevated cardiac troponin. A couple of other biomarkers. So earlier on, I talked super briefly about ANP, atrial natriuretic peptide, which will cause, I think it was dilation to blood vessels. So natriuretic peptides are a whole class of different peptides which have their own effects on blood pressure. But what's important for us is that the presence of some of these is indicative of heart failure. So we have ANP, which is atrial natriuretic peptide, which is released when the atria is distended or under stress. BNP, which is B type of ventricular natriuretic peptide, is it's due to ventricular distension and stress. And then we have CNP as well, which is mostly released by the endothelium. But the function really is vasodilation and inhibiting water reabsorption, so that reduces blood pressure. Reabsorption is when the kidneys bring back water back into the blood. By inhibiting water reabsorption, we allow for water to be released in the urine, which decreases the volume of the blood, which decreases the blood pressure. And obviously, vasodilation would decrease the sort of resistance to blood flow, which decreases blood pressure. BNP and the N-terminal breakdown product, so NT-proBNP, is what we're interested in for heart failure. And I'll talk about that in a second in a bit more detail. So CRP is another one, C-reactive protein. This is very general for inflammation in the body. So it essentially is just a protein, inflammatory protein made in the liver, relevant only to the acute phase of inflammation, not to the chronic, but it essentially activates complement, does a bunch of stuff in inflammation. Okay, so cardiac remodeling. We talked about how these cardiac muscles, the cardiomyocytes, they die due to ischemia, but what happens after that? So cardiac muscle cannot regenerate. So this leads us to tissue replacement by fibrous tissue, that is fibrosis. This fibrous scar tissue is non-functional. It cannot contribute to contractile force, which means the remaining muscle that's left over essentially has more work to do and a greater hemodynamic burden, which is what that means, just more work to do. And this can result in the remainder cardiomyocyte hypertrophy to compensate. Scar tissue, since it has decreased contractile ability, it can lead to the total heart's decreased output, and that leads to heart failure. Heart failure is just the inability of the heart to pump properly. There's two different types of heart failure. So super briefly, there's systolic and diastolic. Now, we don't really think about it as diastolic anymore. We think about it as heart failure with preserved ejection fraction. And I'll show you a diagram super quick just to kind of get a sense of what's going on here. So I said that heart failure is just when the heart is unable to pump blood properly. And if you look at the second, like the diagram or the picture on the bottom, the second heart here, which is hypertrophied heart, this, you can kind of see how like the muscular walls are much thicker, which reduces the amount of blood that can be filled in the chambers of the heart. So this means that since there's decreased filling, there's going to be decreased output, which is a form of heart failure. The second one, which is a dilated heart, which is due to probably damage to the heart or like the muscle walls, that leads to eventually the heart being unable to pump blood properly, which obviously decreased contractility, decreased output, and heart failure. So these are two types of heart failures, which have different sort of like ways in which they occur and how they appear visually. And when you think about a AMI or just an acute infarction in the heart, it looks kind of like the dilated heart, where you have there's an initial infarct, and remodeling with fibrous tissue replaces it with replacing tissue with fibrous tissue leads to reduced contractility, and obviously you can kind of see how an AMI can lead to heart failure later on. And that's it for me.
Thanks, Deepak. I'll get on to presenting. Woo! Oh, almost clicked leave meeting, so that's exciting. Okay, share, not the leave meeting button. Goodness, it's a bit slow, hey. All right, here we go. Can you see that?
Yeah, that's good.
All right, thank you. Yeah, so cardiovascular history, it's definitely very important. Of course, history is generally where you're going to find out what's wrong with the patient anyway. If you haven't got an idea of what's wrong with them after the history, then that's a bit of a worry. And cardiovascular history especially, I think basically every Monsky I've done has been like at least all of the summative ones I've done. Maybe it's by chance, your results may vary, but they've all been on cardiovascular history taking. So it's definitely very high yield and a thing that you're going to get a lot of practice of, and for good reason. In terms of the general history, you know this by this point, hand hygiene, of course, but then, you know, the introduction, confidentiality, consent, identifying the patient, checking that you've got the right person, and noting some of those key factors, their indigenous status. So a brief note there, don't use the acronym ATSI or ATSI. Some individuals or some groups, sorry, find it offensive and discriminatory, and it's actually, that's advised by the Australian Bureau of Statistics. They've been advised by some Aboriginal and Torres Strait Islander groups. So use the full thing. Yeah. All right. And occupation. So all of those sorts of factors are relevant to the patient and relevant to maybe some risk factors or the impact on them from this presenting complaint and associated symptoms. All right, then you go through your HOPSI, your history of presenting complaint, and that's all our WWQQ, aggravating, alleviating, and associated symptoms. and then beliefs, impact, concerns, expectations, all of that good stuff. And then after we've gone through, once we've finished BICE, then we generally progress on to systems review. Now, I'm pretty sure you only have a few systems reviews under your belt at this point. But as you progress along, you'll learn more of them, and you'll start integrating questions from different systems to help differentiate between, okay, this seems like chest pain, but is it maybe more of a respiratory thing once you learn respi next year? Or is maybe there's something gastrointestinal going on? Is it something with their esophagus, so the food pipe, down to the stomach? Maybe they're having reflux and that's what's causing them pain, but it's still generally in the area of the chest or something. So you'll start integrating more questions, but at this point, we're going to go through the cardiac systems review, and that's basically like the most high yield aspect of what we're doing today. Then, of course, you go through past medical history. So have they had any other instances of this presentation, any other past conditions, any current pre-existing medical conditions, immunizations, things like that. Family history, does anything run in the family? Does this run in the family? Do you know anyone in your family who's had a similar thing? I'm just going through this generally. So then drugs, that helpful mnemonic for doctor prescribed, recreational, over-the-counter, gynecological, and sensitivities, allergies. And then smoking, alcohol, that's ETOH, that's an abbreviation for alcohol. Then your social history, so that's your essence, but really like home life, diet, exercise, support, stresses, and a couple I've forgotten, and spirituality. Just mention it for completeness in an OSCE if you have the time, if you're in a Monsky if you have the time. And then you conclude. Thank you. Is there anything else you'd like to add? I will pass it all on to the GP or the doctor or whatever. And then in a Monsky situation, you'll probably be expected to summarize what you've said in about a minute. So yeah, 1 or 2 minutes. I'm not too sure. Check with the with what information you're given. But yeah. All right. So that's the general structure. Systems review is really where we're getting the bulk of our content for this specific topic. So there are multiple mnemonics. I'd recommend paid COPS plus fatigue. Some people like 3D COPS and fatigue, but that also leaves out chest pain, so you probably want to ask about that too. But I'll just go briefly through this, and then I'll comment on some information tables that I got from PSPlatypus from last year. Palpitations is our P, our first P. And that's an abnormal awareness of the heartbeat, or a rushing heartbeat, or sort of a sense of flutter, or it can be different things for different people, but generally some abnormal, I'm more aware of my heartbeat than normal. That's palpitations. Ankle edema, so that's swelling of the ankles, and that's due to fluid buildup. So we can see that in congestive heart failure, so sort of that more generalized heart failure, that would be included under the examples that Deepak just gave you. You get pitting edema. So that's swelling, where if you press down and then you remove your finger, the depression on their skin will remain for a little while. And that just indicates a certain sort of fluid buildup. You have pitting and non-pitting, but that's a bit overboard. Really, we're just asking that, because that's more an examination finding. Really, in history, we're just asking, have you noticed your legs or your ankles have been swelling up? Intermittent claudication, once again, related to that lower leg pathology. So we've got pain in the calves, and that's on exertion. So that's when walking is the main example. And it's usually alleviated on rest. But yeah, that's a key finding. Dyspnea. So that's shortness of breath. And really, when we refer to dyspnea here, we're talking about exertional dyspnea. So you'd ask, oh, do you ever experience shortness of breath? Okay. When do you have shortness of breath? What makes it worse? What makes it better? Things like that. And that's general for all of these. When someone says, yes, I do have that, or if they seem a little bit unsure, then specify, be a bit more clear, but also ask more information, gather more information, quickly, but gather more information on positive findings. So yeah, shortness of breath, exertional dyspnea. So shortness of breath on exertion. So walking or running or climbing upstairs, things like that. Similar with chest pain, check what the circumstances are. But yeah, definitely gain some more detail when you're asking about chest pain, because the characteristics of it can determine whether it's more, oh, this is definitely seeming like a myocardial infarction, a heart attack, or whether maybe it's something else, a ruptured blood vessel, or pericarditis, so inflammation of the tissue surrounding the heart, things like that. Or maybe the lungs, or even something gastrointestinal, as I was saying earlier. Orthopnea, so that is, as we can see, the pnea, that is that air derivation from Latin, I think. Orthopnea means shortness of breath when you lie down. And the reason that you get shortness of breath when you lie down in things like heart failure is because as you lie down, the blood that usually is pulled in your lower body, especially your lower limbs, by gravity, and so it just pulls down and it's usually kept down there. Not completely like it's pumped through, but there's more volume being kept lower in your body because you are standing up and there's gravity pulling it down. When you lie down, you remove that force pulling the blood down to your lower limbs. And so a bunch of venous blood returns to the circulation more than it does usually when you're standing. And because of that, it increases the amount of blood that the heart has to be dealing with. It has to be receiving and pumping back out. And if it's not able to compensate for that, then you might start feeling a shortness of breath because you're not able to oxygenate that blood as much as you could oxygenate the amount of blood that you were when you were standing, when you didn't have that increased load. All right, I hope I explained that relatively well. Paroxysmal nocturnal dyspnea is a similar idea, but it's over a longer period of time. So it takes a bit longer when you're lying down, and presumably when you're asleep, and then you're woken up by this shortness of breath, this attack of shortness of breath at night, usually when you're sleeping, and then you're woken up by it. Compared to orthopnea, where they might just be lying down and that might be worsened immediately. And so a lot of people with orthopnea sleep on multiple pillows so that they're not lying directly down. And that's a way that you can measure how severe the orthopnea is. Syncope is fainting. So that's losing consciousness. And that is another sign of cardiac problems because you're not able to get enough oxygen to the brain. You want to ask circumstances around that as well. If someone says that they have fainted, then ask how long were they unconscious? Was there anyone who witnessed it? What was happening just before? Did you notice any funny feelings before or after? Things like that. And then fatigue. So this sense of tiredness, intense tiredness, which is also to do with that hypoxia, not getting enough oxygen because your blood isn't being pumped around as efficiently as normal. I hope that explains those relatively well. I'll quickly go through the PSPlatypus tables on the subsequent slides. But I'll just quickly say paroxysmal nocturnal dyspnea. Paroxysms are attacks. That's what paroxysm means. Nocturnal, think like nocturnal animals like possums. And then dyspnea, as we discussed earlier. Dys meaning bad, nea meaning breath. So like shortness of breath or difficulty breathing. All right. And then, sorry, very briefly, I spent a lot of time on this slide, so I'm just quickly going through it, or taking a bit more time than I will on the other slides. 3D we've got, and that's just sort of thinking about dyspnea more systematically. So going that exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea, and sort of just grouping them together. So you can ask, oh, do you experience shortness of breath? When do you experience it? Do you experience it on exercising or moving around? Do you experience it when lying down? Do you ever get attacks at night where you wake up and feel short of breath? Claudication, so that's our intermittent claudication, that calf pain. Edema of ankle, so that's swelling, palpitations, the abnormal awareness, syncope, fatigue. And just note that you probably want to ask about chest pain as well. Hopefully the patient will tell you anyway, but make sure that you do ask for each of these things in a systematic way in the systems review. Lovely. So here's the details from PSPlatypus, and they just have some example questions, some ways that you can explain it, and some key concepts to consider and to ask the patient if they say, yes, they have had an abnormal awareness of their heartbeat. What were you doing? Did you eat anything before that might have caused it? Any other circumstances associated with it starting and ending, things like that. And that goes on for each of these. I'll briefly note on chest pain that really this heaviness or tightness is a particularly suggestive sign of a heart attack. I think on top of that, it's sort of just occurring, it localizing to, I think, the left arm. And on top of that, we'll actually get onto the next slide. So the jaw or left arm, central, tight and heavy. And I think also there's this concept that is like this sense of impending doom. And that's another thing that you'll see in heart attacks is someone feels like they're going to die, and they have this abnormal awareness that they feel like they're about to die. So that's a very interesting finding for heart attacks. Okay, and then you have other types of chest pain. So central pain, often preceded by anxiety, and so that could be more so like panic attacks or more sort of psychosomatic. So your brain affecting your body rather than there being a specific physiological pathology. You've got pleuropericardial, so that pain of like rubbing of layers and things like that, and they're worsened by sort of increasing the pressure. But generally that's like inflammation of the pericardium. And then we've got vascular pain, so pain that you'd get from, say, a burst blood vessel or a blood vessel splitting into its outer layer. And so the blood is basically occupying a larger space and causing a lot of pressure, and you're losing blood into that new space. So that's more sudden onset and radiates to the back. So they have different characteristics. Mainly know your cardiac pain for the cardiac systems review, and then just more details on the other parts of that paid COPS fatigue. Okay, going on to the other aspects of the history. So if someone's had a past history of cardiovascular disease, it follows that they might continue to have cardiovascular issues, and it's very important to consider. So what I have here, for instance, ischemic heart disease. So a lot of things that Deepak was talking about. So that blood, insufficient supply, that ischemia. Myocardial infarction, so heart attacks, CABG, so coronary artery bypass graft. So that's a surgery that they might have had to manage their ischemic heart disease. Or their myocardial infarction, not too sure, apologies. And rheumatic fever is, I'm pretty sure, a virus, I think, that you can have that then causes more damage to the heart as it lasts. Maybe someone else would be able to comment on that a little bit more. But yeah, if there are any findings, clarify further. Don't just, if they're like, oh yeah, I've had a heart attack, like ask a little bit more. Oh, when was it? How are you managing? Have you had any more? Things like that. Don't just be like, oh, cool, you've had a heart attack. Okay, you have a billion risk factors for cardiac. Okay, you just said yes, and I've not asked you anymore. You want to ask more. Drug use, tobacco and alcohol use, pretty self-explanatory risk factors for messing with the sort of the sympathetic and other aspects of control of the heart. And then social history as well. We want to consider the other risk factors. So diet, if you have a poor diet, if you aren't exercising much, if you have a lot of stress, if you have poor living arrangements, or if you don't have much social support, all of those things can impact your wellness and your heart, especially your cardiovascular health. And occupation as well. So your disease obviously can affect your ability to work. So I think the examples given in the clinical skills booklet were divers or truck drivers. I think if you have cardiovascular issues, then you may not be able to work in those fields because you may have too much of a risk, or, you know, if you start having a heart attack as you're driving a truck, that poses risk to other drivers as well as yourself. And things like that. But also your occupation can be a risk factor. So it goes both ways. Heart issues can affect the rest of your life, but your life can also affect heart issues. So if you have a really sedentary lifestyle, then obviously you're not exercising as much. There's a lot more blood pooling and just a risk factor for cardiovascular disease. And then finally, family history and other risk factors. So in terms of family history, if they had past heart conditions, if someone died of a heart attack, or someone had a heart attack, especially before they were like 50, in your family, then that's notable as a risk factor. Congenital heart diseases, so especially hereditary ones, ones that you inherited, remembering that the meaning of hereditary is something that is heritable, so is actually genetic in origin, whereas congenital just means something that you're born with. And you might say, develop that as you're being born or something. Let's say for some reason you broke your arm as you were being born, then that might be considered congenital, but it isn't hereditary because you didn't inherit that broken arm from your parents. You just broke your arm. That's an abnormal example, but just distinguishing congenital and hereditary. So I probably mean hereditary here. But yeah, we also just say, yeah, most heart diseases that you'd experience being born with would also have a hereditary aspect. And that's why it's a relevant part of family history. Sorry. And Marfan syndrome is a connective tissue disorder that basically means that people grow to be very tall. They have things like pectus excavatum, so that little dip in their chest, in that sternum area, and very long limbs and fingers. And so a classic example you might see is that then affecting their heart or their lungs, because connective tissue is everywhere and it obviously performs very important connective roles and supportive roles. And so it means that you have vascular risk factors. Your blood vessels obviously have a lot of connective tissue supporting them. And if you have a problem with that, then you're going to have an issue. You're going to be at an increased risk. And then other cardiovascular disease risk factors. So obviously smoking is a massive one, but then also high blood pressure, high lipids in your blood, or high cholesterol, hypercholesterolemia. But yeah, hyperlipidemia, hypercholesterolemia, and dyslipidemia, or sort of within that realm of metabolic syndrome, as is diabetes. So another sort of endocrine disease, but it's a cardiovascular risk factor. And then just some others. So being a male, being older, being obese, so having a higher BMI, and physical inactivity. So even if you are obese, physical activity can perform a lot of protective aspects, and you don't necessarily have to lose a lot of weight. You just have to be physically active. And that can be very protective against cardiac disease. There's one thing in the chat, so I might just see. Think back to cardiac microbiology, rheumatic heart disease due to staph. You make antibodies against it, damaged heart valves, not good. Exactly, Jen. Thank you so much for saying what I forgot. All right, thank you so much. If anyone has any questions, feel free to pipe up. But yeah, definitely high yield. I'd encourage you to practice your cardiovascular history taking, because you will get it time and time again. And obviously it's very relevant in clinical practice as well. You want to be able to quickly go through if someone's having heart issues.